Hi there, and welcome to the Medicine Matters Rheumatology podcast. I'm Claire Barnard. In this series of podcasts, we are looking at the repurposing of rheumatology drugs for COVID-19. This episode is focused on interleukin inhibitors, and we are talking to Professor Cristina Mussini. To start with, Cristina, please could you introduce your experience working with patients with COVID-19?
I'm the director of the Clinic of Infectious Diseases at the Modena University, and I'm dealing with COVID-19 since the beginning of the first wave last March. As you know, Italy has been strongly hit and hardly hit by COVID-19, and it was the first Western country after China to deal with this epidemic.
Quite early on in the pandemic, we started to see some studies suggesting the potential of interleukin inhibitors for treating COVID-19. First of all, Cristina, could you tell me why these agents were considered promising?
The reason why the attention has been focused on interleukin is that while the first phase of severe COVID-19 is mostly related to the action of the virus, SARS-CoV-2, the second part is related to the response of the immune system. And the response of the immune system determines the so-called cytokine storms. And many symptoms are related to the presence of these interleukins, in particular IL-1 and especially IL-6. And we could see it because the inflammatory picture of the patient is so relevant. We have a high value of CRP, of D-dimer, so it's absolutely is all the body of the patient that is inflamed.
So what do the clinical trial data show about the efficacy of these agents for COVID-19?
I have to say that initially there were observational trials. The Chinese started showing a certain effect of tocilizumab, so an anti-IL-6, and an antagonist of the receptor of IL-6, and also that is widely used, as you all know, in rheumatology. Because it was, a pathogenic treatment. On the basis of pathogenesis, they tried this drug. So at the beginning, there were observational studies, and then the trial followed. I have to say that the two drugs that were mostly used were anakinra, so IL-2 antagonist, and tocilizumab and sarilumab for IL-6. Anakinra has shown a few good results in a very small observational study, like the one in San Raffaele Hospital in Milan on 26 patients, and it was promising. But then a French randomized study showed in the interim analysis that there was a higher death rate among those receiving anakinra, and so France, as the first country, stopped all the study, including anakinra. While for IL-6, apart from the first study or the observational study that we have conducted and we published on Unanswered Rheumatology, showing an important benefit in terms of the composite endpoint, that is invasive mechanical ventilation or death. There was a protection for death, for example, of almost 60% in those who had a P-on-F below 150. So it's, the data from observational studies were very promising. But then some study came out. The first one was just a press release, and it was the first one, but we couldn't see the the complete study published, because until today it has not been published. That is the COVACTA, that is the large trial sponsored by Roche, that said that they could not meet the first endpoint of prevention of death, so they decided that it should not be used in severe COVID-19. And it was a trial conducted on 1,000 patients. But we don't know. We don't know the patient, because we have seen that we really have to tailor the treatment in patients with COVID-19. So this study, we don't know. But then, after a short period of time, there was another study that has been now published, but at that time it was a press release, always from Roche, about the EMPACTA study that was similar to the COVACTA, but enrolling only ethnic minorities. And in this case, the primary endpoint of prevention of invasive mechanical ventilation and of death was reached, the combined endpoint, while the endpoint of death was not reached. Apart from this, we have two, we were a little bit confused in our clinical practice. On one hand, we saw the clinical effect of this drug on patients who were failing to dexamethasone and for whom there was no other treatment option. And on the other one, the large trial, one said that it wasn't working, and the other one said, oh no, it is working, but not for that, but just the composite endpoint that includes that. So it seems like it was used not always in the right patient. So it is very complicated to think about this trial. The situation became even more complex when some studies, for example, the one by Carlos Alvarani, the one by Stone, they tried to see if tocilizumab could work as a prevention of the development of cytokine storm, because they enroll patients with a mild disease, not with a severe disease. And in this case, it did not work. So it was absolutely, I think that it's not so surprising, because it's an antagonist of a cytokine. If you don't have the cytokine, why should it work? So was not surprising. But this, in a way, fueled the opinion that tocilizumab was not working. Then, very recently, there has been a press release of the Oxford University, together with some researchers from the Netherlands, of the REMAP-CAP, that is this randomized clinical study that showed, again, as the EMPACTA, that in patients with a severe pneumonia, critically ill, many of them were intubated. They show also an advantage in terms of death of the use of tocilizumab. So on the basis of this study, the NHS, the National Health System of UK, suggests now to recommend now to use tocilizumab in patients with severe COVID-19. And I know that there is a discussion in the DHHS in the US in order to do this recommendation. But this, for example, all these trials were used also from a political point of view. In Italy, the study by Salvarani et al. That wanted to see if it worked as a prevention, as I said, not in the severe pneumonia. So something completely different was used by IFA, that is our regulatory agency, to say that we should not use tocilizumab. And many regions in Italy could not use tocilizumab because of this recommendation against. So this was something very, I think, not correct, was wrong, because you have to need more data, especially because all these trials have been conducted in situations that were absolutely dramatic. And while the one perform as to see if it could prevent it was at the end of the first wave, so really patients with mild disease were enrolled. You have to read the trials and to understand which one could be compared, or what could explain the difference in the results. Now we are waiting for the results of the tocilizumab arm of the recovery trial in UK. I think that if the NHS, on the basis of REMAP-CAP, as now recommends tocilizumab, it's also because they have, I suppose, but interim data showing that there is an advantage in using tocilizumab, because if it was, the opposite, they would have never, they would have said, let's wait for more evidence instead of recommending, but it's just my idea. So we wait also for this.
You talked about the different trials having different patient populations in terms of disease severity. Do you think there might be any other potential reasons that could contribute towards the different results, like route of administration or the time it was given, or anything like that?
Yeah, but it's the same, because the time when it's given is the same as a different clinical picture. So if it could be that it's too early. We have seen the data in our cohort, for example, that are still unpublished. But if the patient has a PONF, so it has a certain grade of respiratory impairment, so a low respiratory impairment, it doesn't work, while it works a lot below 200 of PONF. So it's, as I said, it's important to tailor the treatment on the basis of the clinical picture. So you should not give it too early. It works on and only if the patient is inflamed. So if he has a CRP that is elevated.
What do you think are the most important unanswered questions about tocilizumab for COVID-19 that should be addressed in future studies?
I think that we have to find, as you said before in your question, we have to find the right patient and the right time. We have work in emergency all the time. So now it's time to look at the evidence and to really find which is the best, to find the patient that could really benefit the most from tocilizumab. And when we, sometimes we talk that it's an expensive drug. It's true, but if it saves you from invasive mechanical ventilation, the cost is three times of the one of tocilizumab. Just one day in intensive care unit, it's about 3 times the cost of tocilizumab. So it is really cost effective. And dexamethasone, even in the recovery trial, the death rate in the dexamethasone arm was 22%. So it's a high rate. So it's not that we have to go below 20%. And with dexamethasone alone, we could not do it. There are some patients that benefit of dexamethasone, but in our data, around 30% of the patients will fail. And these patients are, they should go to invasive mechanical ventilation. And if with tocilizumab, we could save this intubation in the majority of them, we would have done a good job, I think. I think that now how we use tocilizumab in clinical practice, we use it when the patient is failing dexamethasone. So we are starting a trial on these patients in order to see if it's, I mean, I'm really convinced. So this is my clinical practice. But I think that to convince the rest of the world, it's useful to have randomized clinical trial. So we will perform a randomized clinical trial, but we will use a safe endpoint in order to leave the possibility to rescue therapy, not to go, against placebo at this point after 1 year when we have seen that it works.
Okay, so we've talked quite a lot about the IL-6 inhibitors, but how about the IL-1 inhibitors? You mentioned earlier that the anakinra has been stopped in terms of investigation in France. Do you think other countries will follow suit, or are there still ongoing investigations into this drug?
No, I think that there are some investigations, because also to stop all the investigation, because you have more death, you have to look at, the reason why this patient could die are so many. So it's important to have a look, not just to stop, but just to have a look at the reason, the causes of death, and understanding what could be drug related and what is not drug related. It depends on the clinical picture of the patient, on the characteristic of the patient, the comorbidities. So it's not just the number in the trial. These are very severe patients, and you have to understand which is the real cause of death before stopping everything, I know that in some Italian centers, for example, I know that for them, the standard of care is anakinra. It's not tocilizumab. As in other one, for example, we have seen also the data of the ACTT2, that is the trial on baricitinib plus remdesivir, so the JAK inhibitor. And in this case too, the results were promising, very promising. It's a randomized clinical trial. So I think that the idea of acting on this cytokine cascade, the cytokine storm, is very, very important, and probably a life-saving strategy in this patient with COVID-19. These are drugs that are used mostly by rheumatologists. So I'm an infectious disease specialist. I'm not an expert in all the drugs that could be available. I have to say that these drugs, especially tocilizumab, but also sarilumab, because even if the numbers in the REMAP-CAP were much, much smaller in the sarilumab, but also sarilumab reached the endpoint as tocilizumab. And this should be correct, because the first study on sarilumab, also in that case, there was a press release saying that it didn't work, as it was for the Covacta for tocilizumab. But still, it is because the patient that were enrolled, it's not that because you have 1,000 patients. You need to go into the subgroup of patients and see which one it could work, while this work on looking at subgroup was not performed.
Thank you very much to Cristina, and thank you for listening. This podcast was produced by Medwire News for Medicine Matters Rheumatology. Please subscribe for more podcasts on repurposing rheumatology drugs for COVID-19. Medicine Matters Rheumatology will also be covering the latest research and guidance on COVID-19 in people with rheumatic diseases. Bookmark rheumatology.medicinematters.com for updates.